Test item cluster for mechanical neck pain likely to benefit from thoracic manipulation includes symptoms less than 30 days, no symptom distal to the shoulder, looking up doesn't aggravate the symptoms, FABQ score for physical activity is less than 12, diminished upper thoracic spine kyphosis, and cervical extension range of motion is less than 30 degrees. Go ahead, Katie, look up. Good. Test item cluster for full thickness rotator cuff tear includes the drop arm sign, where the examiner abducts the arm to 90 degrees and asks the patient to slowly lower it to their side. The painful arc sign, where the patient abducts the arm through full range of motion and the examiner notes any pain. The infraspinatus muscle test, where the patient's arm is at their side, elbow is flexed to 90 degrees, medially rotated 45 degrees, and the examiner applies a medially rotated force that the patient resists. The test item cluster for subacromial impingement syndrome includes the painful arc sign and the infraspinatus muscle test, which were previously demonstrated, along with the Hawkins-Kennedy impingement sign, where the patient is forwardly flexed arm to 90 degrees and the examiner applies a medial rotation. Test item cluster for patients with mechanical neck pain likely to benefit from cervical manipulation includes symptoms less than 38 days, expectation that manipulation will help, cervical rotation range of motion difference of 10 degrees or more between sides. Okay, go ahead and look to the right. Good. Now look to the left. Good. Pain with posterior to anterior testing of mid-cervical spine, where the patient is prone with a pillow under their chest so the head and neck are in neutral. The examiner positions thumbs over the spinous process of targeted vertebrae and applies a gentle posterior to anterior force that assesses pain, mobility, and end feel. The test item cluster for cervical radiculopathy includes less than 60 degrees ipsilateral cervical rotation, a positive Sperling's test, where the patient laterally flexes the head to the symptomatic side and overpressure is applied. A positive distraction test, where the patient is supine, the examiner cradles the back of the head with one hand and the forehead with the other, and gently applies a distraction force. And then a positive upper limb tension test A for the median nerve, where the scapula is depressed, the arm is abducted to 90 degrees, it's supinated, the elbow is extended, and then the wrist and fingers are extended. The upper limb tension test 2B for the radial nerve. The examiner abducts the shoulder 10 degrees and then uses the hip to depress the scapula. The forearm is pronated, the shoulder is medially rotated, and the elbow is flexed to 90 degrees. The wrist and fingers are then flexed. After that, the elbow is extended. The patient is asked to report any symptoms throughout the test. One can sensitize the test with contralateral or ipsilateral cervical lateral flexion. The differential diagnosis between a rotator cuff tear and C5-C6 radiculopathy is as follows. The C5-C6 radiculopathy would present with a positive shoulder abduction test. Go ahead and place your hand on top of your head. Good. I would then see if that changed any of their symptoms. They would have a positive distraction test, a positive upper limb neurotension test, a positive Sperling's test, but a negative Hawkins-Kennedy's test. All these tests were previously demonstrated. The patient would also have limited cervical rotation range of motion to the ipsilateral side. They would have numbness and tingling in the C5 and C6 dermatomes. They would have weakness in shoulder internal rotation, elbow flexion, and wrist extension. And they would have diminished C5-C6 reflexes, specifically the biceps and the brachioradialis. For a rotator cuff tear would present with a positive infraspinatus muscle test, a positive drop arm sign, where the patient may only be able to control movement to a certain point, a positive Hawkins-Kennedy test, but they would have a negative distraction test, a negative upper limb neurotension test, a negative Sperling's test, and they would have normal reflexes and sensation. The load and shift test, where the load portion is done by grasping the humeral head and positioning it in the glenoid fossa. Then the shift portion is done by pushing the humeral head anterior and posterior, noting the amount of translation and the end feel. You have to compare bilaterally to determine atraumatic instability. The active compression test of O'Brien is used to detect superior labral tears. The arm is flexed to 90 degrees and then horizontally adducted 10 to 15 degrees. It is then medially rotated so the thumb is down. The examiner applies a downward force to the arm that the patient resists. The arm is then supinated with the palm up, and the same force is applied that the patient resists. The lift-off sign. The patient places the back of their hand on their pocket. The patient lifts away hand from their back. If the patient is able to do so, the examiner applies a force pushing the hand toward their pocket to test for the subscapularis muscle strength. The supraspinatus or empty can test is used to test supraspinatus tendon pathologies. The patient's arm is abducted to 90 degrees with the hand in neutral. The examiner then applies a downward force that is resisted. It is then moved into scaption with medial rotation of the shoulder or the empty can position, and the same downward force is applied.